6 months or so into ICD-10. And let's take a look back at what happened in 2015, and we'll take a look forward in 2016. And hopefully we will make this fun and productive for you. What I want to cover over the next 50 minutes or so, the very first thing is, why are we still talking about ICD-10? I'm sure for those of you who are here, you probably understand this, but you may have others in your organization who would ask this question. I thought that was something that happened last year. I thought that was behind us. So we're going to jump in and address that right off the bat. So I'm going to spend a little bit of time talking about that. Then we'll look what happened in 2015, what went well, what didn't go well, what do we need to be paying attention to for 2016, particularly the big risks for physician practices. And that's number one, make sure we protect your doctor's time. We cannot turn your doctors into coders. We need to let our doctors be doctors. If they're not taking care of patients, nobody is. If they're not generating revenue, nobody is. And at the end of the day, if they're not doing those two things, they're not going to be happy. And we want to make sure we take care of our physicians. But at the same time, we do have a real revenue cycle need of making sure that the claims get paid completely and correctly the first time. And we have to have the right codes to do that. So we're going to talk about how to balance those two things. As Shelley mentioned, I'll leave time for questions and answers at the end. So use the questions panel for that. And you can use that as we go. No need to wait till the end to hold those questions. Okay, so why are we still talking about ICD-10? You know, if you put yourself, kind of rewind a year, a lot of people were comparing ICD-10 to Y2K, right? There were a lot of similarities. There was the one-day conversion, right? On October 1st, you had to use ICD-10 codes. There was the broad concern across the marketplace, is this going to be a doomsday scenario? Is this going to be industry-wide meltdown, right? If you didn't do ICD-10 well, your claims wouldn't get paid. Those are pretty dire consequences, right? So a lot of people compared ICD-10 and said it's the Y2K of healthcare. The problem with that, I think, is it puts too much emphasis on the lead up to ICD-10 and not enough on what happens after the conversion date, right? You remember with Y2K, if you can think back that far, on January 1st, when nothing happened, that was behind us. We didn't have to worry about that anymore. And that's where the metaphor of ICD-10 and Y2K really breaks down, because most of the work on ICD-10 is still ahead of us, right? We used ICD-9 for 30 years, and we're going to use ICD-10 for at least the next 6 or 7 years, probably longer than that, because ICD-11 will get delayed and delayed and delayed, just like ICD-10 did. So I think the more appropriate analogy of how to think about ICD-10 is it's a lot more like having a baby. Do you remember having your first child? This is a picture of my wife, Emily, and our oldest son, Becker, from, gosh, almost 7 years ago now. But there's a lot of build-up to that day, a lot of preparation in the 9 months leading up to the birth of your child. But the majority of the work happens after that day, right? As a parent, you spend a lot of time, a lot of energy, a lot of effort after your child is born. And yes, there was a lot of preparation that went up to that date. So I really think the right way to think about ICD-10 is more like birthing a baby than it is Y2K. Because a lot of the hard work, a lot has happened in the past 6 years, right? We've had multiple babies since. This is a picture for those of you who I don't know. That's me and my wife Emily and our 3 children, Becker, Thomas, and Anna Grace. And like our family, ICD-10 can sometimes be really smooth for some organizations, and sometimes it can be kind of crazy. That's why we're still talking about ICD-10, because you're going to be living with that for quite some time. And if you ignore it, right, if you do not nurture that, if you do not continue to evolve along with it, that's when things can get out of control. That's why we're still talking about ICD-10. If you remember, in the lead up to it, you probably heard me say this, you probably heard other consultants say this. but Medicare expected that denials would double or triple as a result of ICD-10. That means 100 to 200% increase as a result of ICD-10. That's what the government expected to happen, right? And then when you look at the data after the fact, you look at data published by CMS, what they said was that they didn't increase at all. The denial rate hasn't moved. Some of you may have seen this from some payers, but we haven't seen that across the board. Let me share some of the Medicare data with you. This was published just last month. They looked at and compared the historical baseline, that is the time leading up to October 1st, with what happened in October, November, and December. And what you'll see here, if you look at the bottom row of this table, you'll see that the denied claims rate stayed just about flat, maybe slightly down from 10% down to 9.9%. And the claim volume, the top line, stayed exactly the same. Right? So what this tells us is Medicare expected denials to double or triple. Medicare expected a big increase, but it didn't happen. It stayed flat. And the question that we have to ask ourselves is why? Why did that happen? Were they off in their projection? Right? What was so different? So we've come up with a couple of different scenarios of possible explanations. The first is that maybe ICD-10 wasn't as hard as we expected it to be. Maybe everybody, it's kind of like Y2K or kind of like Chicken Little. The sky is falling. But I don't think that is a realistic explanation. There was a lot of energy, a lot of hard work that went in on the provider community, for vendors and payers as well. But on the provider side, you guys put in a lot of hours to make this a smooth transition for your practice. I wouldn't say that ICD-10 was just a non-event. Possible explanation number two is maybe claims data was much better than what the payers expected. Maybe the providers spent all of 2015, all of that extra time since ICD-10 got delayed, memorizing the new codes, knowing them backwards and forwards, so that they could submit the good quality data that the payers require for ICD-10. Again, that's a possible explanation, but I think it's probably unlikely. I think it's probably unlikely that that explains the phenomenon across the entire industry. Maybe there are a few people that explains their performance. But I really think that the most reasonable explanation, the most likely explanation, is that we haven't seen the real impact of ICD-10 yet. That's still ahead of us, not behind us. And then let me explain why. Let's look back at what happened in 2015. Here's the good news, bad news. We'll start with the good news. The good news is that everyone survived October 1st. We didn't have any kind of widespread industry meltdown, right? All of the stakeholders were prepared. That means the providers were prepared, clearinghouses, vendors, payers. Everybody was ready for October 1st, and the claims process was largely successful. There were a few isolated pockets where some of the payers didn't have their LCDs loaded correctly. There were a few places where I'm sure there were provider groups that were unprepared for ICD-10. But in large part, there was no mass outcry of ICD-10 failure. Patient care did not suffer. And part of this, I would attribute, this is probably the best thing that happened for ICD-10 in 2015, was the CMS grace period. Right? CMS grace period on unspecified codes, where they would, for a period of time, they would not deny those claims. I think that's the best thing that happened as far as physician practice adoption of ICD-10 in 2015. Now, for the bad news in 2015, I would say it's the CMS delayed the denial of those unspecified codes. Good news for 2015, but probably bad news for 2016. Right? That is a stumbling block for a lot of practices. And here's why. Let me explain what happened. What happened was, without those types of consequences, it allows some poor workflows or some poor decision processes to be successful. right? And when there are no negative consequences to those workflows, those bad habits are encouraged, are reinforced, right? There's no reason to change that, under the if it's not broken, don't fix it category, right? And then, because that has gone well, because of the Y2K analogy, because people viewed ICD-10 as a non-event, practice leadership has moved on and is starting to work on other things that need to be done in the practice. Right? Everybody's tired of ICD-10, and I don't blame them for that. But these bad habits are going to cause problems for practices in 2016, and I'll explain why. You look at what happened, what CMS did. On July 6th, they issued a joint press release with AMA, and basically it said they would not deny claims before October 1st, 2016 for unspecified codes, as long as you were in the right ballpark, meaning in the right code family. They wouldn't deny the claim. And they applied that also to the PQRS value-based modifier programs. You wouldn't be penalized for that. Now, this was for Medicare claims only. This did not apply to the commercial carriers, but most of them have taken the same approach. Most of them have followed suit. And I think that's probably in their own financial best interest, right? It was not out of obligation to the industry. It wasn't a law that they were required to comply with. It was in their own financial best interest because they wanted ICD-10 to be successful. But at the same time, they want the more specific data. And they are going to eventually require that. That's one of the big risks for 2016 as we move forward. And the reason why it gives you a false sense of security, think about the workflow. Put your head, if you can, think back to the night of Wednesday, September 30th. Right? October 1st was the next day. And everybody was holding their breath to see how it would go. And on day one, we had all of our staff here ready to help our clients, as did a lot of other vendors. And we watched a lot of practice management vendors, a lot of EHR vendors issue press releases, tweet pictures from their war rooms, declaring victory, saying they had successfully transitioned to ICD-10. And a lot of practices, a lot of administrators, a lot of coders, a lot of billing managers said, not so fast. Let's wait and see what happens when we try to send out the claims. So we waited another week and a half. Claims started going out the door and being accepted by the payer. And the clearinghouses were quick to raise the victory banner and say, no problems here. We have successfully transitioned to ICD-10. And again, payers, the practices, administrators were saying, wait, let's wait till the end of the month and see if these claims are getting paid, right? And now what we've seen, at the end of those 30 days, the denial rate was unchanged. Claims were getting paid successfully. We've seen that again with the Q4 data that CMS released. And the payers were quick to say, we have successfully transitioned to ICD-10. And so what you're hearing is the EHR vendors, the clearinghouses, the payers saying, we have transitioned successfully to ICD-10. If there are any problems down the road, it's not our fault. They are washing their hands of that. And what that means is when the payers start to clamp down, what they're going to do is point the finger back to the physician practice. Say, we are receiving the data. Our adjudication processes are working. All of the pipes, all of the plumbing is connected. The real question we have to ask ourselves is, what's the quality of data flowing through those pipes? Is it the good, clean data necessary to continue a successful transition to ICD-10? Or do we have some bad quality data in there? And what that means is we have to ask ourselves, what ICD-10 codes are you using? What codes are you using most frequently? Do you remember some of the crazy codes that people were concerned about in the transition to ICD-10? Right? This was one of the most popular codes, at least for public ridicule, that flaming water skis encounter. We have looked at 10 million coded diagnoses over the fourth quarter, and we have not seen this code used once by any of our clients. Not one time, right? Now, maybe that's because of the cold weather, but I suspect it's because it doesn't happen very often, right? These crazy codes that people like to make fun of are not the real problem. The real problem and the real danger in ICD-10 are the unspecified codes. There are more unspecified codes in ICD-10 than there were in ICD-9. Did you know that? Yeah, there are a lot more codes in the code set, right? But there's also a higher percentage of unspecified codes in ICD-10 than there were in ICD-9. And these are codes that are being used. You can be very, very vague. Now, when you used unspecified codes in ICD-9, there really weren't negative consequences with those codes. And a lot of people used them as shortcuts. They used it to save time. They used it to save space on a super bill. But there weren't negative consequences to it. And in ICD-10, that's not the case anymore. There is risk to using those unspecified codes. There's short-term risk and there's long-term risk. So let me walk through both of those for you quickly. The short-term risk to using the unspecified codes in ICD-10 is that the claim is going to get denied. And you'll probably see that, if you've not seen that already, in the next 6 to 18 months in your practice. And here's why. Let's think big picture for a minute. Why do the payers want to move to ICD-10? Why did they advocate for that in the first place? Why did they lobby Congress for it? Why did they invest millions of dollars rewriting their adjudication process to handle ICD-10? It wasn't for their health. It was because they wanted the more detailed information on their insured patient population. They wanted the more granular diagnosis information so they could understand what was happening and eventually try to use that data to drive down healthcare expenses. And so if they want and they need that data, and the provider community is not giving it to them, they're going to start to deny those claims. And that's the issue. When they start to require that level of detail, are you providing it to them? Because when they start to deny those claims, that lengthens our accounts receivable. That requires follow-up from the billing and coding department back to the physician. That requires physician time to provide that additional level of detail, right? That's the risk that's still ahead of us, not behind us. We've started to see this from a couple of payers across the country, not very many. If you have seen this from one of your payers, please let me know, or let Shelly know using the questions panel, because I always have other clients that ask me, where else have we seen this? We're just trying to identify the trends as the payers begin. But let me tell you kind of what we've seen so far. So remember, the payers have never done ICD-10 before either. This is new to them. They're going to be making changes as they go. They're going to be learning. They're not going to all do it the same way. They are not going to all do it on the same timetable. And what that means is you may have some that phase in these denials. You may have some that begin that in April. You may have some that begin that in July. Medicare says they won't do it before October. Some may do it all at once, right? What we've seen with Georgia Medicaid, they took a particularly aggressive approach and are denying all unspecified codes. So we encourage our clients who have payers that do that to know what unspecified codes you're using, because some are appropriate and some are not. And you need to be able to push back against the payers if they are denying a claim when you've used an unspecified code appropriately. So that's the short-term risk, and you'll probably see that over the next 6 to 18 months phased in across your payers. Now, the long-term risk, what does that look like? Well, in the fee-for-service world, right, you get paid for the CPT codes. You've got to have the diagnosis on there to make the claim payable, but we're transitioning away from that. The government wants to move to the value-based reimbursement world. That's part of what's going on in the macro legislation and the MIPS program that's coming, that's being phased out, or excuse me, being phased in. Transitioning to that risk-based reimbursement, right? Pay for quality, pay for performance. You can call it outcomes-based reimbursement, whatever you want to call it. In that world, right, this is all about the expected outcome for a particular patient or a particular patient population compared to the actual outcome for that patient. And that is, in those risk-based models, part of that is tied to the acuity of the diagnoses, the comorbidities, how they interrelate. And the more specifically you can use those diagnosis codes, the better positioned your practice will be to protect against flat or declining reimbursement. You have to be able to show how sick your patients are. And we're already seeing that in our clients. Some clients that are part of an ACO already are having to deal with that world. Some clients that have Medicare Advantage plans that are using HCC codes are already in that world. So you can see that's coming. Now, many of you may not see that for another 2+ years. Always hard to tell what the government timing is going to be on that. But there is certainly a short-term risk and a long-term risk to your practice if you're using a high rate of unspecified codes. And that wasn't necessarily the case in ICD-9. So one of the things that we get asked about is, okay, well, how frequently are you using unspecified codes? What do you see out there across the country? So we looked at the data, and what we saw, the national average is over 30% frequency unspecified diagnosis usage. That means on nearly 1/3 of the encounters, you have an unspecified code. 1/3 of the diagnoses are unspecified. That's a big problem. And when the payers start to crack down for people who have that high of an unspecified rate, that's going to be a big, big problem. That's the bad news. Now, here's the good news. When we look across our client base, White Plume clients have done a great job with this. Our clients, on average, are doing 3 times better than the national average. And that's really good to know. Our clients have done a great job with this. You guys have done a great job preparing for ICD-10, making that transition successful. Now, you don't want to just know the White Plume average. What you really want to know is, what is it for your practice? How well are you doing? And this is the first takeaway, the first to-do of what I think you should do after this webinar is make sure that you get those numbers. We can run that report for you and send that to you so that you can see what your unspecified rate is, so that you can break that down by provider. And I recommend sharing that data with your practice, with your colleagues, with your management team, with your physicians, and share the national average with them as well, so that you can say, look, most practices like us have over a 30% unspecified rate. Our team worked really, really hard to make sure that our unspecified rate is lower. Ours is 7.5%. You're doing a great job, doctor. And we are well positioned to continue to be successful with ICD-10 as it gets more difficult during the balance of 2016. I think that is an opportunity to share a success story, and I highly recommend doing that. You need to know what your numbers are. Let me give you a couple of examples of some of the unspecified codes that we've seen from some clients and also from some non-clients, what we see them using frequently and why that's going to be a problem. Here's one that we see all the time, unspecified osteoarthritis, M19.90. Valid ICD-10 code, probably getting paid on claims today. The problem is when you look that up in the code book, you'll see there are 95 other ICD-10 codes for osteoarthritis, right? And the unspecified code is being used 11% of the time. So it's being used disproportionately high, right? If 95 total codes, if it was equally distributed, you'd expect each code to be used about 1% of the time. We're seeing this one being used 11% of the time. It's an outlier. And it's unspecified as far as the type of osteoarthritis. Is the osteoarthritis primary? Is it secondary? Is it post-traumatic? It's also unspecified as far as which joint. The shoulders, the hip, the knee, the foot, the ankle. It's also unspecified as far as the laterality. So this is one of those codes that when the payers start to crack down, this is one area where they may focus first because of its frequency and because of how unspecified it is. Another example, malignant neoplasm of the breast. Again, code used very, very frequently, and this code C50.919, malignant neoplasm of an unspecified site of a female breast, 54 other codes that are more specific in ICD-10. Again, this code is being used very, very frequently. Over half the time where a malignant neoplasm of the breast is coded, they are using this code. And here are the problems. Again, you'll start to sound like a broken record here. It's unspecified as far as the site. Right? Is this the upper inner, upper outer, lower inner, lower outer? The laterality, left, right, bilateral? Right? That's the problem. The payers are going to start to crack down. We should know which side of the body we're talking about. One more time, otitis media. Right? We see this a lot in our primary care practices. Unspecified otitis media, unspecified ear. 80 codes in the code book. This one's being used nearly 60% of the time. We should know which ear we're talking about, right? At the very least. But it's also unspecified as far as the type. Is it chronic? Is it recurrent? Is it serous or non-serous? Which ear are we talking about, right? The payers are going to start to require this detail, and we need to make sure that we provide it to them so that we can prevent those types of denials, so that you can protect your cash flow, you can protect your physician productivity, right? Because let's go back to that workflow process, right? You remember when we talked about this? You've got data going from the doctor to the billing team, to the practice management system, out the door to the clearinghouse and to the payer. That is all working well today with these unspecified codes for most of the country. But when the payers start to clamp down on this, we go back to the beginning of the process and we get in this feedback loop where a biller, a coder, an account receivable employee has to go back to the chart or back to the doctor to say, was it primary or secondary osteoarthritis? Which joint was it? Which side of the body? Right? That takes their time. That takes time up from the doctor. It slows down your revenue cycle process, right? That's the hidden risk that's still ahead of us, not behind us. We try to quantify that to say, what does that mean? What does that really look like? This was a survey, a study that was done by Nachemson Advisors, trying to look at the cost to implement ICD-10 for a physician practice. They broke it down in several different ways by practice size, small, medium, and large. Small was 3 providers, medium was 10 providers, the large practice was 100 providers. So let's just focus on medium for right now. And then they also broke it down into pre-implementation and post-implementation expenses. Right? So the pre-implementation, the top part of this table, those are behind us. Those are done. You've already done your training. You've done your assessment. You've upgraded software. You've gone through all of that. Now the post-implementation expenses, most of those are still ahead of us, right? You might be through all of this if Medicare had not put the grace period out there, if the payers had required this level of detail from day one. But because they haven't, this is where we're going to see those types of problems cost practices significant dollars. And look what the two things that they put out there are. Productivity loss, both for your physicians and for your staff, and then payment disruption in the form of denials. As we start to see the denial rate go up, when payers start to require this data, that is going to cause a cash flow disruption for the practice. We want to minimize that as best you can. Let's take advantage of the grace period and put some processes in place to make sure that you're on the low end of the spectrum, not the high end of the spectrum. Another study that was done looking at the cost to transition to ICD-10 in Canada, this was done by the advisory board. And look what they put front and center here. Physician productivity loss of 10 to 20%. That is unacceptable for a busy physician practice in a fee-for-service world, right? Our doctors aren't salaried. They're small business owners. They're not government employees. They get paid based on their productivity today. And they can't slow down and see fewer patients to deal with ICD-10 coding specificity problems. You look at this and you try to get underneath this data. What they were doing was an increase of 45 to 90 minutes per provider per day to answer these types of coding questions. Right? That's the problem. Even if you cut that number in half, where do your doctors have 22 to 45 minutes per day to answer coding questions? That's not why they went to medical school. That's not what they're interested in. That's not their highest and best use. It's a necessary evil, kind of part of the process that we have here in the United States in order to get physicians paid. But they can't see fewer patients. And it's unfair to ask your doctors to spend this time at the end of the day. And then look at the far left-hand side where it has coder productivity here on the far left. We've been insulated from some of that because of the grace period, right? You'll see coder productivity decline as you get up the learning curve of how specific you need to be. They'll get some of that productivity back, but they'll probably never get back to pre-ICD-10 productivity levels. That's not their fault. ICD-10 is just more difficult than ICD-9. It's more detailed. And then on the far right, again, you see the rework productivity declines. This is the result of payers denying claims, payers asking for more detail, right? Payers rejecting more. We haven't seen this yet. This is still ahead of us. But what you can do is protect against that. So how do you tie these two things together? How do you take your unspecified rate and figure out what the risk is to your providers, to their time, what the risk is to your revenue cycle? Let me show you what we've done to try to at least give you a ballpark framework of how to think about this. Again, we made some assumptions here and assumed a 10-provider practice, that each provider sees 30 patients per day, right? And that each encounter has an average of 3 diagnosis codes per encounter. So that's 10 providers times 30 patients a day, 300 patient encounters. 3 diagnosis codes per encounter, total of 900 diagnoses per day for the practice. Okay? If you have an unspecified rate of 10%, right, that means 90 of those diagnosis codes are unspecified. right? And that means 90 potential denials as a result of those unspecified codes. For a 10-provider practice, 90 denials in a day is a big deal, right? If each doctor, if those are spread out evenly across your doctors, that means you have 9 denials per doctor. And if each one of those produces a question back to the physician, be more specific about the type of otitis media. Can you tell me which year it was in? Can you tell me if it was acute or was it recurrent? Can you tell me about was there any pus or not? Right? Those types of questions back to the provider. Each one of those takes 3 minutes for the doctor to read, research, and respond. 9 times 3 is 27 minutes per provider per day. So you can see very quickly how you get into that area of risk that the advisory board saw in their Canada study. The cash flow risk that you see on the far right, that's 90 denials using the medical economics figure of $25 per denial. 90 times 25 is $22.50. Cash flow risk per day for that 10-provider practice. Right? That's the bad news. Now, the good news is you're probably not going to see all of the payers crack down on all the unspecified codes on the same day. Okay? But there's some risk to that as well. The risk there is that they slowly phase it in, that you don't notice the difference. Right? It's like the old story about boiling a frog. If you put a frog in a pot of boiling water, he jumps out. But if you put a frog in a pot of warm water and slowly turn up the temperature, he doesn't notice the difference. It doesn't jump out until it's too late. That's the thing you have to be careful about, is that this gets phased in slowly. That's why we're talking about this today. That's why you need to know your data, know what unspecified codes you are using, so that you can put process in place to fight back against the payers when you're using an unspecified code appropriately, and make some modifications when you're using an unspecified code inappropriately. Right? So the two big questions for 2016 as it relates to continuing to be successful with ICD-10 is, number one, how at risk is my practice? What is my unspecified rate? What unspecified codes are we using? And then number two is, how do we solve that? How do we get that right the first time? And how do I do that without turning my doctor into a coder? Right? Because that's the important part. That's not why our doctors went to medical school. That's not what they're interested in. That's not what they're best at. So we've got to figure out a way to do that efficiently for them. Okay? So again, what I would recommend is the first step is doing the unspecified analysis. We can do this. We'll do this for you. There's no charge to doing the unspecified analysis. Some of you may already have this. If you do not, let Shelley know. You can use the questions panel for that, and we will get this information to you. And what it'll show you is, here's what your unspecified rate is. Here's how that compares to other white plume clients. Here's how that compares to the national average. And then it will show you, provider by provider, how your doctors are doing. So you'll see down at the very bottom, right, Dr. Andrews is right in line with that national average, but Dr. Bryant is doing great. He's doing a really, really good job. And I get asked this frequently. You're never going to get that unspecified rate to 0. There are times when you need to use an unspecified code because you either don't know, right? That's the only thing that you can code, or sometimes there's not a code for what you need to code. Even with 69,000 codes in ICD-10, right? That doesn't enumerate all of the possible things that can go wrong with our patients. The other thing that comes with this report is it will show you your top 10 unspecified codes. Which ones are being used most frequently across your practice? And also what the more specific codes could be. So you can see here in this example, there's pain in an unspecified shoulder, right? That's a symptom. We should be coding that to either the left shoulder or the right shoulder, right? Or you could code it for both shoulders if it was bilateral. We should not be using that unspecified code. The next one, otitis media, we already talked through that, right? We shouldn't be using that code either. So I would recommend step one is making sure you know your numbers, making sure you know where you are today. Most of you will be doing significantly better than the national average. Take this information, digest it, share it with others in your practice. Then step two, what I would recommend as a step two after you've done that is we've got a second part to this webinar series that really talks through your analysis and shows you how you can make some small changes in Excel-Capture and in Excel-Smart or Excel-Mobile to reduce your unspecified rate, right? To make sure you do get the right code the first time and to build the rules to catch anything that slips through the cracks. We've got that webinar coming up. It'll be April 5th. The next one is April 5th at 1 o'clock Central Time. So you'll be getting an email about that. If you want to go ahead and get the registration link, again, you can let Shelley know, and we will get you that link so that you can get registered and signed up. So I would recommend doing those two things as the next steps, so that you're prepared for that. Now I know I went through a lot of this information, and I know I went through a lot of it quickly. Okay, but let me do a quick summary review before I open it up to try to answer any questions that you may have. So the first point is ICD-10 was born on October 1st, right? That's when the journey started. That was not the finish line. Okay, so what that means is, yes, we've made a good first step. You have done a great job on this so far, but you've got to continue to make changes to your ICD-10 strategy. We have to be prepared for the changes that are coming from the payers. And the best way to do that is to get ahead of them and know what your unspecified rate is. What does that look like for your practice? Right? And then once you've got that information, you may need to make some workflow changes. And you want to do that in a way that protects your doctor's time. Right? You always want to protect your doctor's time. And the second part of that is make sure that you get the right code the first time for the revenue cycle, that you build in a process, that you make changes to your tools so that you're going to get the claims paid completely and correctly the first time. You're well ahead of your peers in that regard, and that provides some protection, right? If the rest of the country is doing 3 times worse than you are, right, the payers probably won't be able to crack down as quickly and as completely as they'd like to without having some major pushback from the other practices. But we want to keep you ahead of that curve, okay? So that's why I recommend getting the analysis, understanding what that looks like, and then I recommend also coming back to that next webinar so we can talk about here are the next steps, here's what you need to do next. So thank you so much for your time. We appreciate all the hard work that you guys put in to make ICD-10 successful, make ICD-10 successful for your practices, make it successful for White Plume. I recommend getting that analysis and recommend coming back for the next webinar. But I hope this was a helpful piece for you today. What I'm going to do is I'm going to go ahead and get the questions from Shelley so that we can answer as many of those as we